today we're going to do examination of the hip and groin. Before we start, just a few quick questions. Any pain in your lower back, hips,
No.
knees or lower legs?
No.
No. Great. So currently pain free. Okay, so first of all we're just going to do a simple observation. We're looking from the front, okay, we're looking for iliac crests to be level and symmetrical. Any obvious external rotation of the lower legs, equal distribution of weight throughout balance. Okay, looking from the side, any obvious flexion deformities, or any stooping of the spine, absolutely normal. And just spin away from me, please. Just observation from the back. Again, any asymmetry of the spine itself. Looking for any muscle wasting, level of the iliac crests. Okay, and any wasting of the buttocks and the gluteus. We're going to assess the bottom of the lower back, just because any referred pain from the lower back can exacerbate, simulate hip or groin pathology. Okay, so just while we're here, we're going to palpate down the lower spine. Okay, down the bony structures of the lower spine. Okay, and spin and face the wall for me. Okay, we'll just finish that off. We'll palpate across the iliac crests, sacroiliac joints for any tenderness. Grand. We're just going to check the range of movement in that position. So what I want you to do, Dan, is just flex forwards for me. Good. So good lumbar flexion and back. Push your bum forwards and lean back. So good lumbar extension. Grand. Any pain throughout those range of movement? Good. Okay. So now I'm just going to check your gait, so your posture. What I want you to do is just walk towards me, turn around and walk back. Okay. So we're looking for an equal waist distribution throughout gait. We're looking for any Trendelenburg gait or any hip swinging or asymmetry of weight and posture throughout walking. There was normal heel toe strike, normal gait there, so no concerns. Okay. Brill. Just while we've got you stood up, one of the tests that I do want to do just for the sacroiliac joints is what we call the stalk test. So if you just turn and face away from me, okay. So I'm just going to have a feel over the sacroiliac joints, and as we're testing your right leg, I just want you to raise your left leg and just lean back for me. Good. And back again. Good. So Dan's got good ipsilateral function of his sacroiliac joints without any exacerbation of pain there. Grand. Jump yourself up on the couch for me. Okay. So simple observation from the front. First of all, looking for any obvious external rotation, leg length discrepancy, particularly important in the juvenile athlete for conditions such as the slipped upper femoral epithesis, or slightly younger, the child athlete with problems with avascular necrosis. But there's no obvious external rotation and no leg length discrepancy. Okay, and that can be measured formally, but I'm not going to do that today. Okay, we're going to check neurovascular status. So we're going to have a feel of the posterior tibial pulse, absolutely fine. Dorsalis pedis pulse, absolutely fine. Capillary refill distally, less than 2 seconds, so good vascular status of the feet. No obvious wasting of the arches, again indicates no neuromuscular pathology. Okay, we're going to check the myotones, so I just want you to pull your feet up towards yourself, and we're going to test that against resistance, so good power on those myotones. Keep your toes pulled back, okay, and push down for me. So a good general screening there of the myotones in the lower limb. We're going to check sensitivity. Can you feel me touching you equal both sides?
Yeah.
And on the inside?
Yeah.
Okay, and a little bit higher up?
Yeah.
Yeah. Good. So equal, comparing both sides, we're checking sensitivity of the lower limbs there. No obvious neurovascular deficits. Okay, just before we go on to assessment of the hip, it's worth mentioning that the Doha Consensus of 2015, which has been described by Weir et al. In the British Journal of Sports Medicine, actually found very little clinical accuracy in the diagnosis of groin pain, and suggested that actually we, instead of determining a particular pathology, that we categorise groin pain into one of 4 clinical entities. That is pubic pain, inguinal pain, iliopsoas pain, or adductor pain, or more laterally, hip pain as a cause to groin pain, or considering we're doing a hip examination today, more laterally, trochanteric and iliotibial band pain. Okay, we're also going to consider today some buttock causes of hip and groin pain, including the piriformis. Okay, so any pain in your hip or groin at the minute? No. It's particularly important to ask the patient to localise to this pain, because that can be beneficial in determining one of these 4 clinical entities, or more laterally the hip pain. Okay, so we're going to assess the range of movement now. Okay, so we're just going to do external rotation, internal rotation in extension. Okay, can you raise this leg up for me and back down? Okay, so good flexion and quadriceps, and can you open your legs apart for me? Good. So that's good. Abduction, and just cross your legs, and good adduction. Okay. Can you flip over for me? Okay. So just into this position, we're going to check for hip extension, and in particular, this pulls on the iliopsoas. Can you lift this leg for me? Grand. So he's got good hip extension, good stretch of the iliopsoas there. Okay. Just while we've got Dan in this position, before we flip him back again, I'm going to move on to just palpate some of the structures of the posterior hip. So we're going to palpate the piriformis, the deep sciatic notch, and the pubic tubercle, the insertion of the hamstrings. Okay. Now there's no exacerbation of symptoms there. Piriformis in particular is important because in approximately 15% of patients the sciatic nerve runs through the piriformis rather than below it, and can cause a sciatic type picture of buttock, hip and leg pain if there's stimulation of the piriformis on the sciatic nerve. Grand, flip yourself over for me again, Dan, if that's okay. Okay. So we're now going to check some of those movements against resistance. Okay, so can you lift this leg up for me again, first of all? So just while we're doing that, Dan's got a good range of movement, indicating, again, no sciatic stretch. Okay, and back down. Okay, just keep it there for me. Stop me pressing down. Good. So good quadriceps. Bend your knee for me. Good. Good iliopsoas. Okay. Bring your leg out for me. Just want you to push down for me. So good extensors there. Okay. Grand. Squeeze your feet together. Good adductors and apart. Grand. So again, gluteus is powerful. Power is 5 out of 5 throughout. Okay. We're going to check the internal and external rotation and the strength in that as well. So just bring your knee up for me. Can you turn your knee out for me? I'm just going to press against my hand. Okay. So we're there. We're checking power of internal rotation. Pull against my fingers. Good. So power of internal rotation again stretches the piriformis, and any exacerbation may get piriformis syndrome. Back down, good. Okay. We're going to then palpate some of the structures of the anterior hip. Okay. We're going to start laterally. Palpate the anterior superior iliac spine, anterior inferior iliac spine. Palpate along the inguinal ligament, the pubic symphysis, pubic tubercle. Okay, no spot tenderness there. Just bring your leg up for me and relax it out slightly, and palpation of the adductors indicate no obvious adductor issues there, which is classically known as the groin strain. Okay, just while we're in that position and we're testing some of those structures, I just want you to just try and sit up for me. Okay, and just as we're testing against resistance, again, relax back down what we're doing there is stressing the abdominal muscles, the insertion of the abdominal muscles, and the aponeurosis on the pubic symphysis, which may indicate iliopsoas type pathology. Okay, bro. So we're going to go on to do some special tests, I think. Can you bring this hip up for me? Okay. So we're just going to stress this into flexion, internal rotation, external rotation. Any particular spot groin pain there, or any clicking or locking, is we're looking for potential joint pathology, labral tears, cam lesions, and those type of things. And Dan's got a good range of movement throughout full flexion, internal and external rotation. Okay. We're going to move on to a couple of special tests before we run out of time. We're going to do the Patrick's test, which is the classical Faber test. And what I want you to do is bring this hip up, externally rotate. Okay, and we're just going to bring that down. Okay, so the figure 4 test, the Patrick's test, any exacerbation in that position may indicate sacroiliac joint pains. Back up, and then we're going to do the Fadir test. So internally flexion, internal rotation, and adduction. We're looking for any stretch of the piriformis. Again, both of these tests have not really been shown to be sensitive or specific enough for diagnostics. Used more as a screening test, okay, to locate hip pathology. What to do? Just lie you on your side, Dan, if that's okay. Okay. Just while you're in that position, I just want you to lift this leg up for me. We're going to feel over the greater trochanter for any trochanteric bursitis. Stop me pushing down. Good strong iliotibial band. Okay. And what I want you to do is just drop this leg down. Okay. And any stretching of the iliotibial band, sometimes we get a popping or clicking over the greater trochanter. None of that there, so that's fine. Jump yourself back up, and you can lie on your back again for me. Grand. So we've done a couple of special tests there. One of the other things I want to do is just a percussion test. So just while we're in this position, I'm just going to tap on the heel, okay, to try and stimulate any pain in the hip or groin. That may indicate an occult stress fracture. There's also been a test that's been shown to have sort of 95% specificity, 85% sensitivity, which is the patella groin tap. So with my stethoscope, ideally I'd like to auscultate over the hip joint and tap on the patella and listen for any unusual sounds which may indicate an occult stress fracture. Okay, grand. So we've managed most of those without exacerbating any pain. Therefore we're going to do some simple special tests, if that's okay. Do you want to stand yourself up for me? Okay. Just while we're in that position, we can just check a general functional assessment of the lower leg. Can you stand on one leg? On your right leg, sorry. A good assessment of balance, weight distribution. There's no laxity, no dropping of the hip, no Trendelenburg there. And can you squat? Good. And back up for me. Again, while we're in that position, I just want you to do what we call the breaststroke kick. So knee up, internally rotate, bring it out and down. Okay, so just like that classic breaststroke kick. Okay. Now again, in the adolescent athlete, this is particularly limited in slipped upper femoral epiphysis and those type of conditions. Grand. There's no exacerbation of those pains. Jump yourself back down. Grand. So we've not indicated any pathology that classifies down into one of these 4 clinical entities of groin pain, and we've got a good general assessment of the range of movement, the power throughout the structures of the hip, and the no obvious sort of lateral causes of hip and groin pain or posterior contributing factors, sacroiliac or lower back pathology. So this concludes our examination. Thank you very much for your help.